Hi, I'm Malathi, Assistant Professor, Child Health Nursing and College of College of Nursing. Today we are going to see about the protein energy malnutrition. What is meant by protein energy malnutrition? In the statistics shown the protein energy malnutrition in the sense India has the highest number of students stunted kids with the 46.6 million children who are stunted. India tops the list of the countries, followed by the Nigeria. 13.9 million people have affected by the stunted. The stunted in the sense delayed growth and development, repeated infections, and getting a baby have to low weight and have to develop the different types of disease. It's called as a stunted, and they followed by Nigeria. In Pakistan is 1010 by 7 million people have to affected by the stunted. In this content I have referred by the India Today in this 2018. And the definition of protein energy malnutrition. Protein energy malnutrition is an inadequate intake of protein and energy, either the dietary intakes of these two nutrients or less than required for normal growth, or the need for growth or greater than the supplied by what otherwise would be adequate intake. In the sense protein energy malnutrition, in the sense inadequate intake of protein and energy by the children, that is called as protein energy malnutrition. The deficiency of protein as well the energy, that is called as protein energy malnutrition. Let's see about the causes. In this causes, perinatal factors. The baby have delivered by the low birth weight baby. It is main causes of baby getting protein energy malnutrition. And second one is yearly cessation of prolonged continuation of breastfeeding. This is one type of cause. And multi-gestational pregnancy. In this multi-gestational pregnancy, they taken care of the baby is a proper manner, inadequate breastfeeding. That is the main cause of multiple gestation. And the next one is lactation failure and poor maternal health. In the sense lactational failure and poor maternal health, in the sense if the mother is getting low nutritive diet and low consent of getting proteins and vitamins, in the sense baby have to deficiency of breastfeeding, that is may affect the lactation if the baby is going to protein energy malnutrition. Next causes is customized illiteracy spacing. If maybe having a customized and the illiteracy spacing have to is one type of causes, and poverty also one type of cause of protein energy malnutrition, and repetitive infections for the baby is also one type of protein energy malnutrition. In this chronic vomiting of the baby after taking the food and before taking the food, baby have to continuous vomiting, in the sense that is also one type of cause. And next one is congenital anomaly. In this congenital disease may cause the developmental delay of the baby. Next one is we will see about the classification of protein energy malnutrition. In the sense first one is Gomes classification. In this Gomes classification, we have to separate in the 3 grades according to the nutritional status and wait for the age and percentage of expected. In this nutritional status, normal is 90%, greater than 90% is normal. According to Gomes classification, a first degree of protein energy malnutrition in the sense 75 to 90%, and second degree of protein energy malnutrition in the sense 60 by 75 percentage of percentage in the weight is called as second degree malnutrition, and third degree protein energy malnutrition in the sense if the baby is getting less than 60% of body weight. And then jellyfish classification. Next one is jellyfish classification is same like that. Nutritional state is comes under the 4 category. In this normal is same Gomes classification in 90%, and first degree protein energy malnutrition in the sense 60 to 90%, and second degree protein energy malnutrition in the sense 70 to 80, and third degree protein energy malnutrition in the sense 60 to 70, a fourth degree of protein energy malnutrition in the sense less than 60%. And syndromal classification of protein energy malnutrition, it comes under the 5 category. In this kwashiorkor. A kwashiorkor in the sense cross deficiency of protein with associated of energy inadequacy. This is called as kwashiorkor. And next one is marasmus. Marasmus is cross deficiency of energy due to insufficient calorie intake. And energy and calories is insufficient in the sense marasmus. Kwashiorkor in the sense protein and energy have to inadequate in the sense kwashiorkor. Okay, and then marasmic kwashiorkor in the sense overlapping of features of both marasmic and kwashiorkor. Both the protein and energy and then calories may have to defect, the both combined is called as marasmic kwashiorkor. That is overlapping of features both the marasmic and kwashiorkors. And pre-kwashiorkor in the sense features of kwashiorkor without edema is called as pre-kwashiorkor. And nutritional draft in the sense low height and low weight for the age. Both growth and development have to delayed by the nutritional draft. Next one, the types of protein energy malnutrition. In this type, first one is kwashiorkor. In this kwashiorkor derived from the language of Ghana, which means the sickness of the weaning. Wilson first used this term in his year of 1933. It referred to inadequate protein intake and responsible calories, energy and intake. In this also called as wet protein energy malnutrition. It is characterized by protein deficiency with the tried symptoms of edema, lethargy and growth failure. It was appear at the age of 12th month when the breastfeeding is discontinued. In this kwashiorkor may develop in the protein and deficiency of energy is called as a kwashiorkor. And in this followed by kwashiorkor, pathophysiology of kwashiorkor in the sense decreased protein intake, decreased synthesis of vesicular protein. It can lead to decreased vesicular protein as hypoalbuminemia and contribute to extravascular fluid accumulation. It has impaired synthesis of beta lipoprotein and fatty liver and edema. This is the main pathophysiology of kwashiorkor. In this kwashiorkor, we have to divide it into some categories and gradings. In this grade 1, a baby is getting fetal edema. Only fetal edema have to present in the sense that the main symptoms is called as grade 1 kwashiorkor, and grade 2 kwashiorkor in the sense fetal edema plus facial puffiness is called as grade 2, and grade 3 is fetal edema and facial puffiness plus edema of the chest wall and paraspinal area is called as grade 3, and grade 4 is fetal edema, facial puffiness, edema of the chest wall and paraspinal area, and then ascites is called as a grade 4. I have to divide it by the gradings of kwashiorkor in the sense grade 1, grade 2 and grade 3 and grade 4. It's according to the signs and symptoms of the kwashiorkor. In this clinical features of kwashiorkor in the sense dry scalp skins and changes in the skin pigmentation, decreased muscle mass, and then growth failure and flanky paint deformities is main clinical manifestation, and hair changes. In this hair changes, thinny, scanty, easily pluckable and lustreless and brownish hairs have to developed by the hair changes by the kwashiorkor babies. Increased and more severe infection in this kwashiorkor and protruded by the abdomen, edema, moon face apathy and irritability, prominent physical MR also developed by the kwashiorkors. Anemia and hepatomegaly, diarrhea, rickets and scurvy is also developed by the main clinical manifestation of the kwashiorkor. And next one we see about the marasmus. In this marasmus derived from the Greek word marasmus, which means weathering or wasting. In the sense marasmus have to weathering or wasting. It is form of severe protein energy malnutrition characterized by energy deficiency and emaciation. It is the marasmus. In this pathophysiology of marasmus in the sense due to cause inadequate calorie intake, a decreased cortisol production, it can lead to increased in plasma cortisol. It leads to lysis of protein and fat. It can lead to severe muscle wasting and loss of fat. And grades of marasmus and grade same like that kwashiorkor. The marasmus have to divided by the 4 grades. In first one is marasmic grade 1 is loss of subcutaneous fat in axilla and groin, and grade 2 is loss of subcutaneous fat in axilla and groin. It does loss of subcutaneous fat in the gluteal region also. And grade 3 is both the loss of subcutaneous fat in the axilla and groin, and then gluteal region also have to loss of subcutaneous mass, and loss in plus have to grade 3 is loss of fat in the chest wall and paraspinal region. In this grade 3, 4 is grade 3, grade 1, grade 2, grade 3 have to combine by the loss of buccal fat of the fat. Next one is marasmus clinical manifestation, in the sense gross wasting of muscles, a poor muscle tone, a complete loss of subcutaneous fat, prominent bones, uncovered fat and muscles, shrunken buttocks is called as a main clinical features. In this, scaboid abdomen with visibility of peristalsis, to hold man face or monkey face have to appear by the marasmus, and loose and wrinkled with loss of elasticity, and marasmic purpura have to develop, and apathetic and less active, cried loud when hunger. Diarrhea is followed by constipation, severe growth and retardation. And next one is marasmic kwashiorkor. In this severely malnourished child, features of both marasmus and kwashiorkor. Features of edema of feet and legs and also hands. Lower arms, abdomen and faces develop. There are also features of muscle wasting. And next one is nutritional draft. In this nutritional draft, in the sense weight and height of both reduction in the same proportions. And the next one is underweight. In this underweight, children's weight subclinical protein energy malnutrition can be detected by their weight for age or weight for height, which is or significant below the normal. And investigations of protein energy malnutrition, both the kwashiorkor and marasmus, and undernutrition and marasmic kwashiorkor and drafting, all the conditions is comes under the some of the investigations is protein energy malnutrition. Have to check the hemoglobin or peripheral smear, serum albumin have to check, blood sugar and electrolytes have to check the and CBC, in the sense complete blood count, ESR, erythropoietin test, and culture have to take, and urine routine and culture have to take, and stool routine and stool culture have to take, and lumbar puncture, cerebrospinal fluid examination have to take, and X-rays, ECGs and Mantox test and gastric aspiration have to check by the investigations. In this management of protein energy malnutrition, in the sense both all the conditions have to some main management, in the sense protein energy malnutrition. Initial treatment, you have to give a 1 to 7 days of life. The life-threatening problems were identified and treated in the hospital. Metabolic abnormalities are revised and the feeding is begun. If the baby is getting protein energy malnutrition or any condition, kwashiorkor, marasmic kwashiorkor and draft and undernutrition, you have to deduct previously 1 to 7 days, in the sense you have to give a treatment started by the 1 to 7 days, they have to recover it. Okay. In this rehabilitation, 2 to 6 days, intensive feeding was given to the recovery most of the lost weight. Mother and caregiver are trained to continue care at home, and preparation are made for discharges. And follow-up, in the sense 6th weeks to 6th month. After discharge, nutritional rehabilitation and care is continued at a home along with the regular visit. And next we will move on to the treatment and prevention modality. In this treatment, we have to follow by the 10 steps of treatment. And first one, step 1 is hypoglycemia. In the sense, hypoglycemia, in the sense baby getting a glucose source have to detected, that is called as hypoglycemia. The glucose tolerance detected, in the sense if the baby is conscious, give 50 ml of 10% of glucose or sucrose, or give a 75% of diet by the mouth. Okay. And next one is, if the losing of consciousness, if the baby is conscious, in the sense you have to provide 50 ml of 10% glucose sucrose, or give a 75% of diet by mouth. If the baby is losing conscious, give a the baby is losing the conscious, in the sense give a 5 ml per kg of 10% glucose IV followed by 50 ml of 10% of glucose or sucrose by the nasogastric tube. When the gaining of consciousness immediately began given by the 75 or glucose orally, 75 ml of glucose per orally. Prevention is child should be feed at least every 2 to 3 hours day and night. We have to feed the child after recovering of hypoglycemia 2 to 3 hours once have to give a day and night, you have to give a feed to the baby. And next one is hypothermia. Cover the child with warm cloth, maintaining a body temperature with radiant warmer. Gangaru mother care have to provide it. Give appropriate antibiotics. Monitor the rectal temperature frequently. Treat hypoglycemia and severe systemic infection. This is the main steps have to followed by the hypothermia. And dehydration. Started dehydration orally with Rizomal. It was prepared by the dilution 1 packet of standard WHO recommended ORS in 2 liter of water and adding 50 gram of sucrose and 40 ml of mineral mixed solution. Give a 70 to 100 ml per kg of Rozomal over 12 hours. Starting with the 5 ml per kg every 30 minutes for first 2 hours orally or by the Hench tube. And then the 5 to 10 ml per kg per hour you have to start. And next one is electrolyte imbalance. If the baby is getting electrolytes imbalance, this is the step 4. Give a supplemented potassium 3 to 4 mmol by kg per day for 2 weeks. One day, give a 50% magnesium sulfate IM once 0.3 ml per kg have to give a electrolytes imbalance. And next one is infection step 5 and cortisol 25 mg per kg BD orally for 5 days have to administer. Injection ampicillin or tablet ampicillin have to give by the IM or IV or oral have to ampicillin 50 mg per kg IM or IV 6 hourly once for 2 days have to give. In this amoxicillin 15 mg per kg orally. In this 8 hourly once for 5 days have to give. And gentamicin in the sense 7.5 mg per kg IM or IV OD for 7 days have to give the to prevent the infection. And mebendazole have to provide 100 mg BD for 3 days have to given by the step 5 infection of protein energy malnutrition. In the step 6 is micronutrient deficiency. Give a vitamin A 5000 international unit orally of less than 6 months and 1 lakh international unit for 6 to 12th month year and 2 lakh international unit for greater than 12 years and folic acid 5 mg per day on day 1 and day 10 mg per day for next day. You have to give a step 3 of micronutrition deficiency. If the 7th step is begin feeding, in the begin with the 2 formal diets and feed 100 and French 75 have to give. Feed 75 used in the initial treatment and feed 100 used in the rehabilitation phase. And give a feed 75 135 ml per kg per day every 2 to 3 hours. And step 8 is achieve catch up growth. After 2 to 7 days of when the child has become hunger, make gradual transition from the 75 diet to equal amount of 100. Children should be feed every 4 hours of 24 hours. For anemia administered elemental iron 3 mg per kg per day. And step 9 is emotional and play stimulation. Provide tender loving care. Plan for structural play and physical activity. Provide cheerful stimulating environment. And step 10 is prepare for discharge. If the baby is all the nutritive supplies or hypothermia and then low grade infection, idellame have to prevented. After prevention, you have to prepare for the discharge, gaining the weight of the baby and a normal rate. All vitamins and mineral deficiency have been treated and full immunization program have to started. After that, have to plan the treatment. Next, we will move on to the complication of protein energy malnutrition. In this protein energy malnutrition, a main complication in the sense dehydration, and next one is hypoglycemia, hypothermia, electrolyte disturbances, infection, severe anemia, hepatomegaly and rickets. And these are all the main complication. We have how to prevent the protein energy malnutrition. Exclusive breastfeeding for 6 months. Nutrition supplementation after 6 months have to give. Regularize the immunization and deworming. And avoid stoppage of feed during fever and diarrhea. And growth monitoring have to maintain. And nutritional education have to provide by the parents. And nutritional surveillance visit have to taken by the healthcare workers. And implementation of family planning and programs have to taken. Promotion of education and illiteracy have to taken. Thank you.